I'm delighted to introduce Dr. Dennis Jensen, who is the director of the UCLA Hemostasis team, has been so for many years after he established it. He is the co-director of the program at the CURE research program at UCLA and the VA, and is professor of medicine, and is, I'm sure, known to each and every one of you as one of the international experts in the field of endoscopy for the treatment of gastrointestinal bleeding. And he's going to talk about some new techniques that I think you'll find very interesting.
Thank you, Bennett, and good morning. I guess we'll have to restart this. My emphasis on this talk is twofold, actually. To review, sorry, this is going to take a second. This got turned off. To review some recent studies that we've done that extend the visual cues that we use at endoscopy to treat variceal and non-variceal bleeding, and also to review the vascular anatomy for you, and then some of these technical issues, including what we've been starting to use, this Avesco over the scope clip, which is a interesting device. I'll comment on the end. About comparative comparisons. So by way of recent review of the prevalence of, first with upper GI bleeding, we finished recently a 5-year randomized trial that looked at this at UCLA and the VA. And among 1,000 patients, what's interesting is ulcer has decreased down to about 31% as the prevalence. Varices now 31%, and you see these other diagnoses that are the final diagnosis arrived at in patients who were in the hospital for upper GI bleeding. The two groups that I will focus on a little bit more are non-variceal bleeding, which is peptic ulcers, Dieulafoy's, Mallory-Weiss tears, and then in the portal hypertension variceal group, it'll be esophageal varices, gastric varices, other portal hypertensive lesions that were included in a randomized trial, including post-banding ulcers that bleed and Mallory-Weiss tears in the face of portal hypertension. So first on the non-variceal side, you're all familiar with the Forrest classification and the descriptive classification of stigmata of hemorrhage, which are shown here. These are interesting, but what the problem is that's been highlighted is it doesn't get us to appreciate the underlying vasculature, which is really what we want to treat here to prevent rebleeding. And you can get at this now with a Doppler probe, which gives you auditory cues. So there isn't any reason not to use both visual and auditory cues for treating GI bleeding, and I'll discuss the reason for that in a few minutes as they increase and improve outcomes. This is a device that we've used for the last several years. It's a Doppler probe, endoscopic, with two different size catheters, upper and a colon, that are in different lengths. It gives you a gated auditory signal that detects at a superficial level up to 1.5 millimeters. The middle one is 2 to 4 millimeters. Those are the two we use for respectively non-variceal and variceal bleeding. We don't use the deeper setting, which is more than 5 millimeters because of extraneous noise, so to speak, outside the wall of the gut. In the first part of this trial, which was reported last year on non-variceal bleeding, these are the stigmata of hemorrhage that you see. We included flat spots, which aren't treated endoscopically usually, but in this trial they were if the Doppler signal was positive. The others you're quite familiar with and would treat endoscopically according to current guidelines: active bleeding, oozing, visible vessel, and clot. What are the types of lesions that were included in this trial of 150-some patients? 85% of them were ulcers, although we found also Dolichois lesions in about 13%, Mallory Weiss in a small proportion, and other ulcers, which would include surgical anastomotic type ulcers. Looking at the 30-day outcome of same rebleed on the bottom, if you look at standard therapy, that was patients randomized to visually guided therapy that we would use, which it usually in our institutions include injection of epinephrine and either cautery or clipping through the scope clipping. Doppler group, we interrogated the lesions before, did the visually guided treatment, and as my group has reported earlier, about 30% of the time with these sort of stigmata in ulcers particularly, there's still residual arterial signal. And so in this trial, when the investigator thought it was safe, they applied more treatment, either cautery, clipping, and or injection. And you can see in the middle column, the standard group rebleeding rate was 26%, and in the Doppler group, it was 11%, which is highly significantly different in this study. Other outcomes were that more units of blood were transfused, although there were no differences in other transfusion requirements or hospital days. The second part of this study, if you want to look at it this way, is a separate randomized trial of lesions related to varices, and these are typical of what we would see at UCLA, obviously. Actively bleeding, spurting esophageal varix. In general, because of how much blood it would be in that case, many of you probably, particularly the younger cohort of people, would not use this. We would use sclerotherapy first to just stop the active bleeding point and then go down and band all of the varices. In the Doppler group, we would have checked it before to see whether there was a venous hum, do the treatment visually. If there's still residual flow, particularly in the varix with a stigmata, then usually sclerotherapy would be done to obliterate that. Similarly to the ulcer trial where more treatment was applied. As with the non-variceal group, at least about 30% of the time after visual treatment of these large varices, in particular those with stigmata, there's still residual flow in the varix, which is why they rebleed. Sclerotherapy, just for those, particularly the fellows, in a cartoon, how do we do this? In addition to stopping the bleeding, with each varix, if you were to use sclerotherapy alone, you treat distally about 3 centimeters above and 5 centimeters above with about a cc or so of sclerosant. Most of us don't do that anymore. We only use it either acutely with horrendous bleeding or when the varices are too small to band. But this is how it's done. If you don't treat each varix, because these are an anastomosis, they'll rebleed. We also treat, in this trial, large varices with veins on veins as a presumptive bleeding site when no other lesion was found. And then this guy, which is a platelet plug on an esophageal varix. Now, most fellows would go down, especially those interested in interventional endoscopy, would go down and band right on this point. That's not the way to treat this unless you're like a little kid with a stick in a bee's nest. You would go distally and band distally first, including all the varices, distal to this a couple centimeters, and then as you're finishing, you would band proximally, and if the visible vessel was still there, thirdly, then you would go on this. If you suction this, remember, this is the side hole of it's a clot that's affixed to a large channel, and in this case, it's about the size of your finger. So there's a lot of flow there, and you're going to wish you weren't there if you suck this off and it starts bleeding horrendously. Just to remind you, based on old anatomy, the slide on the right, these are anastomoses. Most of the time they bleed in the distal esophagus because they're closest to the surface there. But these are venous structures. Most of the time in cirrhosis, it's uphill flow. So if you take this Doppler after you've done your work and you test proximally if the varix is there and there's still flow there, you know that it's coming through the area you want to obliterate. Just by way of background, this paper is going to be presented at the ASGE as a plenary session, but on this second trial, which was in patients with portal hypertensive lesions, the standard group had 47 patients, the other group 49. If you want to look at the syllabus type material, they're matched in all regards that we would think would be important, including age and hemoglobin, coagulation, prognosis score, mean transfusions, etc. However, when you look at the primary outcome, which was 30-day rebleed rate from this lesion, as presented previously, in the middle column is the results of the standard treatment, visually guided, where the rebleeding rate was 36%. In the Doppler group, it was 15%, which is highly significantly different. So as with non-variceal bleeding, this Doppler, the auditory cues in addition to visual cues for treatment were the way to go as far as this outcome. In addition to that, we looked at other features, including the need for surgery. Most of the time it was liver transplant, TIPS, et cetera. There are no differences in those outcomes. However, there were differences, as you might expect, related to rebleeding, in that the number of bleeds, the number of transfusions, including red cells and fresh frozen plasma, were significantly lower in the Doppler group, as were the total hospital days, because if you have another rebleed, it's going to make you stay in the hospital longer. So presenting this as a histogram, the two studies are shown side by side. On your left are the results of the non-variceal. On your right, the variceal. The red is standard treatment. What's shown is the primary outcome, which is 30-day rebleed rate, highly significantly different, favoring the Doppler treatment. By the way, this is easy to use. They're disposable catheters. It takes about 30 seconds to 45 seconds before and after to use this. It doesn't increase treatment time. And for those of us cannot hear, we ask the technicians whether they can hear it. So it's easy to get help from your team. I want to now switch to a different topic, which is lower GI bleeding, but it emphasizes the same issue. What are we trying to do here? We're going beyond the visual cues. Shown here are some of the typical stigmata of hemorrhage, which our group has identified and published recently about in conjunction with what the Doppler correlate is. So adherent clot in the middle is a diverticulum with a visible vessel, and then obviously on the right is active bleeding. So as to the proportion in the 100 patients we've seen diagnosed by urgent colonoscopy, the most common finding is an adherent clot, about equal or non-bleeding visible vessel, and the active bleeding, about 30% of the prevalence. Reminding you about the anatomy again, these are related as far as the vascular anatomy to a arcade of arteries formed by the joining of a submucosal and a subserosal vessel with a mesenteric vessel. There's bidirectional flow. So if you have a diverticulum with a stigmata of hemorrhage in the base and you try to treat at the neck, it's not going to do any good. Similar to non-variceal upper bleeding, the goal here is to get rid of the flow where the disruption in the artery is. In this case, as shown, it's in the base of this at the non-bleeding visible vessel. So we would go at that with clips, one on either side. What are the type of lesions that we've seen? This is a recent update of the 8 most common colonic lesions that we've seen as diagnosed by, most of the time, by urgent colonoscopy after purge. So it's some 700 patients. The most common is diverticular bleeding. All of the ones that are checked, we would treat endoscopically, not necessarily the same way. But diverticular bleeding, that's definitive with stigmata. Ischemia is the next most common. It's rare to treat focal lesions in that because most of the time they're diffuse. Of course, hemorrhoids, which Gordon Owning is going to speak to you about, we usually ban in an emergency situation. We're treating rectal ulcers, usually not the colitis. Of course, we treat colon angioma syndromes and radiation with APC or cautery, and then a large population that we now have that's increasing a delayed post-polypectomy bleeding. These are examples of what we see in a patient who would come back a week after we all would perform a routine polypectomy. A lot of these patients are back on aspirin, Plavix, ginkgo, echinacea, occasionally anticoagulants, and they bleed. And what you see are stigmata of hemorrhage. A is active bleeding, B, a spot, C, clot, D, a visible vessel. And if you were to explore these with Doppler, 90% of the time you find that there's an artery under there then which is treated, often with clipping. We've seen now about 85 cases of delayed post-polypectomy bleeding at the VA and UCLA over the last 15 years, and the prevalence of that is increasing quite a bit. Why is that? We're not really sure, but a lot of it is based on comorbidities that I've mentioned. The second, a risk factor, is polypectomy in the right colon, and of course the third one is the size of the ulcer that you get when you take a polyp out. I'm speaking about benign polyps, not malignant polyps. And then we have the interventional group who are also seeing a lot of very large polyps because of referral patterns, and they have a fair number of bleeders. Why do these patients bleed? Well, this shows the cut section in the lower left, and just above that in the 3 o'clock position, there's a large artery there. So we don't know. I mean, this did not bleed during the polypectomy, but once you remove the polyp, you are left with an ulcer. And you can't see the arteries, they're translucent. But what is very interesting is if you use a Doppler probe, you can locate the artery. And if you do that in high-risk patients and treat it either with clipping or with a bipolar probe, for example, to obliterate it, the patients almost never rebleed. If you leave them alone in high-risk patients, the current rate of that in some 70 patients or so we followed is that the bleeding rate is up to 20%. If they're the bigger the defect, the more likely they are to bleed in a delayed fashion because the coagulum sloughs off in about a week, and it exposes the underlying arteries. And if you have patients who are on antiplatelets or anticoagulants, they can bleed. To nail that down just a little bit, if you look, as we did in this case, this series in some 60-plus patients, in the lower left are patients whose post-polypectomy ulcer, that is right after you remove the polyp, what you see in the wall side, if it's less than 10 millimeters, only about 8% of the time can you detect an artery, so we don't mess with those unless they're really high-risk patients. However, if the post-polypectomy ulcer is between 10 and 15 millimeters, 28% of those have a detectable artery by Doppler. If they're larger than that, more than 15 millimeters, the percent or the prevalence of a detectable artery goes above 60%. So you see, this is one of the risk factors that hasn't been recognized until now. What do we do now with this? And this is the basis of a new randomized trial that we're starting at UCLA and the VA. Well, now what we do is we use the Doppler probe. If we localize an artery, we focally treat it, usually with clips, but if you cannot clip it because of access issues, you can cauterize it using a bipolar probe because that's the safest. You've already removed part of the wall. So by way of summarizing this new issue of preventing post-polypectomy induced delayed ulcer hemorrhage, our studies have shown this. The risk factor, and others have reported these, the risk factors for this problem include large ulcers, right colon location of polyp, bleeding during the polypectomy that you can stop, the use of antiplatelet or anticoagulant drugs, and an artery detected in the base by this Doppler probe. We've also, in this large series of patients coming back because of delayed post-polypectomy bleeding, find a high prevalence of stigmata, and if you look at those stigmata by Doppler, most of them have arterial flow, and if you obliterate that, then they don't rebleed. This is an important issue from the literature, and it sort of parallels some of the things that Ollie said about anchoring things. For post-polypectomy ulcers that are 15 millimeters or bigger, Hemoclip closure doesn't work. Most of the time you can't really close them even with a zipper technique. If you do, you bury the artery. You bury the arteries with this technique. The clips fall off usually within a week because what they are anchoring is the cauterized tissue, which actually sloughs off. And when they fall off, which most of the time they do in the colon within a week, it exposes the artery, and that's why they bleed. So we know, based on the data I've shown you, you can use a Doppler probe to detect these arteries, and whether that actually prevents delayed bleeding in high-risk patients is a subject of a current trial. So if any of you have patients with large polyps that are high risk, we welcome referrals to UCLA, or if they happen to be a veteran there too. Many of us, including some of the senior gastroenterologists, Dr. Roth, are going to be participating in this study, so you can refer the patients to your friends. These patients will be randomized either to Doppler-guided risk assessment and treatment, or standard treatment, which is just to stop the medications like the anticoagulants and then restart them. But again, in 7 days, they're back on these. It doesn't make any difference. The artery is still there. They can bleed. What else are we doing? This is a doulofoid lesion, which of course are hard to detect sometimes. It's a raw artery without an ulcer. And these things tend to have big arteries in them. And they are one of the kinds of lesions with visually guided treatment that fail with either standard clips or cautery. Why is that? Well, this is a histologic picture, and you see the mucosa and then this large artery, and then up in the apex of this is a quant. These are large arteries. They're hard with these small clips we have to obliterate, and the clips may not get deep enough to actually grab the appropriate tissue. So the advantage of clips, though, is shown here as opposed to MPEC, which is cautery, is you don't see that brownish material, which if you look at under the microscope is tissue damage. None of the clips, regardless of what kind they are, who makes them, don't cause such tissue damage. So that's why they're so appealing, particularly in high-risk patients. They're not big enough, though. They're not strong enough. They can't do the job in a lot of cases. So we're starting to use in high-risk patients this over-the-scope device, Ovesco, and it is comes in various sizes. We don't usually use this drilling or grasping device. The best thing in non-variceal bleeding is to suction the lesion into this and fire it. And as mentioned by Raman, this is in the hands-on area, and I invite you to take a look at it. This shows, it looks like jaws here on your left, which is, if you first look at these things, they're sort of frightening. They come with different sizes and configurations, which you can get an idea of in the lab. We can't give you the local results. We're doing a randomized trial of this in high-risk non-variceal lesions as compared with usual therapy, Doppler guided here at VA and UCLA. One other update on a clip that you can look at in the exhibit area, BSC now, like the other companies, has a more rotatable clip. From our standpoint, it works well. It doesn't have the sheath. Our preliminary results indicated that for lesions you can't reach with the regular clip or get a clip on, this one or two of these may work very well. For example, diverticula that you can't get into the base of, or tangential lesions. It wouldn't necessarily need to replace the regular clips that we have that are cheaper, but in some of the difficult cases, it's useful in the armamentarium. So as far as Hemoclip comparisons, I would refer you to this. It doesn't matter what the through-the-scope clips are, BSC, Cook, or Olympus, as compared with the Ovesco, this large device. Most of the through-the-clip ones are disposable, only one size. They are rotatable. The Ovesco is not rotatable. The grasp depth here is important. At most, the through-the-clip scopes will grasp 2 to 3 millimeters, whereas this Ovesco can get big chunks of tissue up to 5 millimeters deep. The cost of these clips depends on your institution. The through-the-scope ones are $150 to $200, whereas the Ovesco is about 3 times to 4 times that much. The limitations are in both groups of clips. The through-the-scope clips, in my opinion, there's only single size. They cannot grasp firm tissues such as ulcers or fibrotic areas, and they're okay for small arteries, but they can obliterate bigger ones such as doulofois or some high-risk ulcers. The limitations of the over-the-scope or the Ovesco clip are that you can't pass it through strictured areas. The position pretty much has to be on FOSS, so you cannot use it where you can't get on FOSS. And then the deployment, there are some issues with deployment. You can't always deploy these where you want them. I remind you about the vascular anatomy. We're trying to get rid of blood flow under the lesion that's bleeding right near or at the stigmata. That includes doulofois, and with varices it's the same, although we use banding or sclero with this. The same with diverticula, go where the money is. Now, this is different than angioma syndrome such as watermelon, where they're superficial vessels. And with this, we can neither detect blood flow with this Doppler device, nor do we use these focal therapies such as clipping. Cautery is the way we usually treat these, APC or MPEG probe. Similarly with radiation. So you're dealing with small vessels. It may be, there's other treatments that have been used, both medical, including formaldehyde, and more recently, some want to use not horns, but want to use topical agents. So looking at non-variceal GI bleeding and comparing on your left the stigmata of hemorrhage as opposed to what you would use. And I want to particularly comment in the far column on hemosprays or topical. I'm not going to spend a lot of time on these. To my knowledge, the nanopowder hasn't been approved yet in the United States for endoscopic use, although there's some case reports and small trials. But I would caution you on interpreting them, and the enthusiasm by my group is fairly limited. For major stigmata of hemorrhage, such as I mentioned, active bleeding, visible vessel adherent clot, hemosprays or topical agents would have no role. They don't do anything to the vessel. Maybe for oozing or flat spots, which only less than half the time can you detect an artery. If you didn't know anything better, you could spray some of that stuff in, but it's not definitive. For angiomas, no, because you want to get rid of and destroy the underlying vessels, whether it be radiation, watermelon, or isolated angiomas. Where it's been used, and we don't have the results yet, are in cancers or diffuse bleeding. A trial is underway in Canada. We don't usually use, except for very focal cancer or polyp bleeding, we don't use MPEC or clips. We could, though, if there was a focal lesion. This is an example of how, with an angioma in the right colon, when we were cauterizing this with a fellow, it kept bleeding. And so there was a little artery there, which I'm not showing you the video, that kept pumping. So in this case, we just put 2 clips on it, and you can do that, they'll fall off. It obviously stopped the bleeding, and in this high-risk patient would achieve good hemostasis. We don't usually do that with angiomas, but it is an option. What about variceal and portal hypertensive lesions? Would we use hemospray or topical? In no case, whether it's varices, hemorrhoids, post-RBL ulcers, or Mallory-Weiss tears, would we use that, whereas we'd use the old standbys of sclero and banding. Rarely would you use Hemoclips. You could use a Hemoclip if there was an artery in a post-polypectomy ulcer or Mallory-Weiss tear as detected by the Doppler. So again, I would remind you there's many opportunities in the foregut to use hemostasis, but the goals here are to get the job done during one treatment session, and that's best achieved currently, at least by our group, by using visual cues, stigmata of hemorrhage, and this Doppler probe. Thanks for your attention.